So the first and main conclusion is that screening general population with NT-proBNP turns 54% positive cases with point-of-care device and 46 with lab test. The second, so many subjects would meet heart failure guideline criteria for the next step, and that is imaging. The second conclusion is that the point-of-care device can reliably be used to make this stratification whether the subject is positive or negative per heart failure guidelines. Because there is the severe lack of epidemiological studies in Europe and also worldwide. So whenever we speak about prevalence, we refer to a figure, prevalence of heart failure is 1 to 2%. But you need to remember that in the last 20 years, there are only a handful of studies that have been published about prevalence of heart failure. So we decided that we need to do something about it. You need to also to appreciate that in the last 20 years, many things have changed. So population has aged, diagnostic criteria for heart failure modified, and you cannot really say that using the old definitions and previous populations still apply for today's conditions. So that was the reason that we are looking for new information, and we believe that the prevalence of heart failure is higher than we think. Well, first, we asked Statistical Office of Republic of Slovenia to provide us with the highest possible sample of inhabitants in Murska Sobota city older than 55 years. So they gave us 60% of that population, and that is more than 2,800 people. So in this study, and then we invited everybody with a personalized invitation letter for the visit in the lab, where we drew blood to do the test with point-of-care device, and they needed to fill in the self-assessment questionnaire about cardiovascular disease, cardiovascular conditions, symptoms of heart failure, any cardiovascular procedures they might undergo in previously, and medication. So with this information, then we separated subjects in two groups: those who have had NT-proBNP concentration 125 picograms per milliliter or higher, and we invited them for a diagnostic workup, which takes about 2.5 hours per subject, and we do comprehensive echocardiography, we draw blood, we take urine, we do pulmonary function testing, body composition assessment, couple of exercise tests, ECG, then history taking and physical examination. So in every subject with NT-proBNP 125 or higher, and in 12% of those with, so to speak, normal NT-proBNP to have the control group. In this presentation that we present today, we compare the point-of-care NT-proBNP with the laboratory method, because we have had some samples stored from the screening visit, and to test whether point-of-care device measures NT-proBNP in a reliable way, to differentiate between those who meet the heart failure guideline criteria for further step, and that is imaging. Well, first message for the clinical use is that point-of-care device can reliably be used in the GP setting to identify patients with non-acute onset of heart failure. So to say whether the NT-proBNP is elevated, and then to refer a subject for a further imaging or any other diagnostic workup. So this is the first, and I believe the main message that can impact the clinical practice. The second thing I would again emphasize is that according to our results, with point-of-care device, 54% of population would test positive. So that is a huge number, and this proportion increased with age or with worsening of renal function to 100% in some subpopulations. So, stating then that this is a screening test. If you are 100% positive in your sample, then you should think about modifying either the cutoff to say this is positive, or to go with another screening modality in these subpopulations.